Hi, Tracy Franklin with you. Going to talk about the topic of EMS systems and EMS history. And this is a preparatory lecture for paramedic students. When we talk about EMS systems, we talk about chiefly the role and responsibilities of the paramedic. And although we are still considered ambulance drivers, that is only one component of what it is we do. Today's paramedics are an integral part of the healthcare system, and the activities that we perform, the skills that we can provide, improve quality service and improve patient care in the field and beyond. So where we're at now is still fairly new, comparatively speaking, in the healthcare scope of practice, but it's a far cry from where we were in the beginning. So a couple of things we're going to talk about in the development of EMS is how did wartime influence EMS and what happened in the 19th and 20th centuries that changed or created the need for EMS. So pre-hospital emergency care obviously is going to have its roots in wartime or in military medicine. In the late 1860s is when we saw organized civilian ambulance services in New York City and also in Cincinnati. But during the Civil War, it was the Surgeon General, Jonathan Letterman, who actually created ambulance services for each Army Corps. And this is because during the Battle of Bull Run, a little man named Walt Whitman, he noticed that there were so many soldiers, thousands of soldiers that lay in the field for days on end during the Battle of Bull Run. So after the Surgeon General, Jonathan Letterman, created these ambulance services for each Army Corps, we noticed during the Battle of Antietam that there were roughly 10,000 wounded soldiers transported by these Army Medical Corps that were attached to these medical units. So started to see even in the 19th century that pre-hospital care, field care, especially for trauma, was going to be an important part of our society. Now, the initiation of medical care in the field and rapid evacuation were super important during the Vietnam War and during the Korean conflict. We had during the Iraqi conflicts and the Afghanistan conflicts, we noticed that our trauma care improved extensively, and that's because we were using synthetic blood components and we were using clotting agents. We understood better the pathophysiology of trauma care and how the body responded to wounds. So that's how wartime influenced modern EMS systems. Now in the 20th century, we had a paper that came out. We refer to it as the White Paper, written in 1966. So during that time, of course, we're coming off the heels of, some pretty big battles in American and world history, yet we have more people dying on American highways than we did during battle. So there was this white paper that was written by the National Academy of Science, the National Research Council Committee on Trauma, and the Committee on Shock. Paper is called Accidental Death and Disability, the Neglected Disease of Modern Society. Basically, that paper says we're losing more people on the highways in car wrecks than we are during war. What can we do to fix it? So Congress said, we will fix it. So Congress enacted the Highway Safety Act of 1966. Part of this Highway Safety Act was the development of the Department of Transportation. Once the Department of Transportation was created, the National Highway Traffic and Safety Administration was then formed, and its sole responsibility is to provide legislative authority and funding to improve emergency medical systems and help states to develop emergency medical systems in their area. In order to help the states, the federal government said, listen, we'll help you up to so much money to try to form your own system. And if you don't form an EMS system, then we're going to cut your road highway funding by 10%. So the states didn't want to lose any money. They certainly didn't want to lose the highway funding. So they started developing regional EMS systems and local EMS systems. That brings us on down to 1973, when Congress passed the EMS Systems Act. And this act allowed states to get federal funding to support their EMS agencies. So that worked pretty well for us from 1974 all the way up through 1981. And in 1981, we had something called the Omnibus Budget Reconciliation Act. And basically what this act did is take the funding from the states and put that money into preventative healthcare service block grants going to health departments. So effectively what the Omnibus Budget Reconciliation Act did was eliminate the EMS System Act of 1973, took the money that the states got for EMS and gave it to health departments. Because I'm sure by 1981, there were more people dying from medical diseases than there were car wrecks. So that's where the funding needed to go. So the downturn to that is EMS sustained no growth from that period. The funding was taken away. The states didn't have the money to self-fund. They relied on those federal funding, and so EMS became stagnant. The National Highway Traffic Safety Administration could no longer support those EMS systems, and that brings us to where we're at today. So what does healthcare reform mean for EMS? Well, we can tell by the previous explanation that federal reform directly affects care provided by EMS. Managed care organizations control reimbursement rates for EMS providers, and currently Medicare and Medicaid reimburse EMS agencies as transport suppliers rather than healthcare providers. And most insurances are going to follow whatever Medicare and Medicaid do with their money. And the reason why they can pay us as a transport rate is in 1966, when we were formed, we were put under the Department of Transportation and managed by the National Highway Traffic Safety Administration. Therefore, at federal level, we are considered a transport entity and not part of a managed healthcare system. So in 2010, we had the Affordable Care Act that was passed, and basically the Affordable Care Act changed managed healthcare plans into accountable care organizations, which means that doctors and hospitals and other healthcare providers have to work in the form of a team in order to provide patient care. So if the patient's overall treatment is expensive, then all of the team members have to share the cost of that treatment. What that means is healthcare providers will receive less money. And now that creates an incentive for these accountable care organizations, these team providers, to be innovative in how they treat patients. And their goal then becomes, let's treat the patient outside of the hospital because it's too expensive to take the patient to the hospital for treatment. Let's see if we can do all the treatment outside of the hospital. That, ironically, is paving the way for mobile integrated healthcare, also known as community paramedicine. Unfortunately, it still does not provide better funding for EMS. So what does our current EMS system look like? Well, we said in its inception, we were put under the Department of Transportation and managed by NHTSA. And coordination was initiated by NHTSA to develop program standards for EMS programs. Local agencies are responsible for providing the day-to-day EMS care in the community. Local agencies also work with regional and state agencies to set standards and guidelines that we should all follow. And at the state level, state agencies are responsible for licensing and certification. And states also enforce EMS regulations, and they help develop public education programs. A lot of times your state agency will act as a liaison with national agencies. Some of those national agencies would be National Highway Traffic Safety Administration, Federal Emergency Management Association, the Department of Homeland Security, and the Department of Health and Human Services, which would be like your health department. Now, I want to back up just a second here. Did you know in 1971 there was a television show called Emergency that came out? I've actually never seen an episode of Emergency, although I'm told that it was a pretty good show. It became popular. It helped educate the public on what it is that EMS providers did. And it was also around that same time that a lot of fire departments decided they wanted to get in on this EMS thing as well. So just to let you know, in 1966, when we were conceived, we were standalone agencies staffed by volunteers, sometimes mortuary services, sometimes hospitals, rescue squads. You know, it wasn't until the 70s when we were attached to fire departments. Now, who determines EMS education? Well, for the purposes of students at Somerset Community College, there are lots of standards. But overall, EMS education is managed by these agencies that you see listed here. In the before time, we use something called the National Standard Curriculum. It's not been updated since 1998. It was a good jumping off point, but like I said, you know, we are young in terms of being a medical profession. So this was our starter document. EMS Education Agenda for the Future, a systems approach, came out in 2000. And one of the goals of the agenda is to develop a robust educational system for EMS professionals built on science and sound educational principles. There are 5 parts to the agenda to ensure quality EMS education. So one of the 5 parts is we have to have core content. This is our bare minimum that we should know. We've got to start with the core content, and then we can build off of that. But across the nation, from California to New York, Everybody needs to understand the core content. By the way, all of these documents are online, and I can provide you with links to these documents. That way you understand what it is you should learn during the course of this program. So the National EMS Scope of Practice Model was written in 2007, and it defines the minimum knowledge and minimum skill level at each level of certification from first responder on up to paramedic. So the National EMS Education Standards and Instructional Guidelines is a template that I use in our paramedic program to write course curriculum and to write exam questions and to make sure you understand the bare components of what you're required to know to obtain a national certification. The standards also define the knowledge, competency, and clinical behaviors and critical thinking judgments for each level of certification from first responder on up to paramedic. Also, the education agenda said we need to have a national EMS certification. So right now, the agency that we all use for a national certification is the National Registry of Emergency Medical Technicians. You know, 20 years from now, 30 years from now, there may be another agency that offers national certification based on the scope of practice model and the education standards. Right now, National Registry is the only one. The education agenda also said for the 5th component, we need to have program accreditation, which means this program follows certain instructional guidelines. It validates its testing process. It looks at the content that it's laying out there. It's under continuous quality improvement in the educational realm, and we certify that this program is doing what it said it can do. So right now, paramedic programs are accredited through the Committee on Accreditation for EMS Education Programs, and we call that COA for short. So there again, the 5 parts to the EMS education agenda for the future is core content, scope of practice, national standards, nationalized certification, and nationalized accreditation of EMS education programs. Now, training in EMS, we have emergency medical dispatcher, first responder, EMT, advanced EMT, and a paramedic level. The paramedic comes with an extended scope of practice, and we will talk about that in just a second. So your dispatcher is responsible for receiving and processing calls for EMS assistance. They should also contact and coordinate EMS resources like ground ambulance, helicopter, if you need lift assistance, if you need rescue assistance, you need a wrecker service, whatever it is. The dispatchers are responsible for coordinating that. They also relay medical information. They coordinate with other public safety agencies, and they can provide some instructions over the phone for medical emergencies. First responder is a certification that we don't see a lot of anymore. Primary focus for the emergency medical responder is to initiate immediate life-saving care, and they have a basic knowledge and they can perform basic skills with very minimal equipment while waiting on an EMS response. When we get to the EMT level, EMTs are trained in all phases of basic life support. That includes an AED, administration of some medications. They can assist advanced EMTs and paramedics, and they can provide transport. Advanced EMTs It's a little bit harder to describe the level of training for an advanced EMT because that's going to change based on different states and based on different EMS systems within those states. The primary focus, though, of the advanced EMT is going to be basic and some limited advanced medical care and transport for critical emergent patients who call 911. When we get to the paramedic level, paramedics are trained in all aspects of basic and advanced life support procedures. They have advanced training in patient assessment, in clinical decision making, in cardiac rhythm interpretation, in defibrillation, drug therapy, and airway management, and they provide care based on their advanced assessment skills and the formulation of a field diagnosis. When we talk about an extended scope of practice, we're speaking specifically about these 5 things: critical care paramedic, flight paramedic, community paramedic, tactical medic, and wilderness medic. These extended credentials are going to change state to state, and currently there is a certifying exam for 4 of these 5 extended scopes of practice. So for critical care, flight, community, and tactical, you can be certified, and that makes a difference between a credential and an endorsement. You can take a class and be endorsed by your medical director to perform certain procedures, but if you take a credentialing exam, then that gives you this extended scope of practice. There is a lot of national EMS group involvement, but there are 3 main agencies that we're going to talk about. So FICEMS may be somebody that maybe you've not really heard of before, the Federal Interagency Committee on EMS. It was created by Congress in 2005. And their purpose is to identify measures that improve federal agencies' efficiency with regard to EMS. They work to coordinate federal agencies all the way from the state and local levels on up to tribal, regional, and national EMS systems. FICEMS recommends starting new programs or expanding old programs, and they have a total of 11 national members on their committee. So NEMSAC, National EMS Advisory Council, was created in 2007, and their purpose is to provide consultation to the Secretary of Transportation and to the Federal Interagency Committee on EMS. They have no regulatory authority, but they represent the EMS community on a national level, and each of those members serves a 2-year term. If you go to the NEMSAC website, you can find an application to apply to be a community member, to be an EMS representative, and you can be part of the changes that go on in EMS if that is of interest to you. So our legislative agency who sets our EMS standards would be NHTSA, National Highway Traffic Safety Administration. And again, they were developed through the Highway Safety Act of 1966. They are positioned under the Department of Transportation, and they provide legislative authority and funding to EMS. So now that we've covered this in a couple of separate slides, you can see why we are paid a transportation rate and not a medical healthcare provider rate. It's because we fall under NHTSA, who is positioned under the Department of Transportation, and that our EMS Advisory Council answers to the Secretary of Transportation. So if we want to change how we are viewed, how we are perceived, maybe our reimbursement rate, we probably should look at moving ourselves at the federal level under a healthcare provider agency. Now, this is something that a lot of people get confused about, but I'm just going to give you a very clean definition. What is the difference between licensure, certification, and credentialing? So, a certification granted by a state and conferring a right to engage in trade or profession is a form of licensure. So that comes straight from the Sanders Paramedic Text 5th edition. Page 18 will be right there. So basically, licensure is how we regulate occupations. Government agencies issue a license. Certification says you have obtained a certain level of training. You are adequate to perform a task at a certain level. That's a certification. Registration is enrolling your name in a record, and that would be done through the National Registry. Credentialing is a local process, and it says your medical director says, yes, because you have a license and you are certified to operate at a certain level, then I credential you to work under this certain level. Primary responsibility of a paramedic should be professionalism. Professionalism refers to a body of knowledge or expertise. Professionals regulate themselves through licensing or through certifications that confirm competence or can show competence. Sanders Paramedic Text, 5th edition, page 19. Professionalism refers to the way in which a person follows the standards of a profession. It usually includes adhering to a code of ethics. And within my paramedic program, we do something called effective behavior grading. So I grade you on integrity, empathy, self-motivation, appearance, personal hygiene, self-confidence, communication, time management, teamwork, and diplomacy, respect, and patient advocacy. These are hallmark attributes of professionalism in the paramedic realm. Basically, integrity means that you're being honest. Empathy is when you identify with and understand the feelings that someone else has. That could be your coworker, that could be your patient, that could be someone else on scene. Self-motivation, you have drive and self-direction. It means you can follow through on a task and nobody has to stay on top of you. Professionals should be clean and should be concerned with their appearance. Your clothes ought to be in good repair. You ought to take a bath. You ought to brush your teeth. You ought to comb your hair. Self-confidence is super important. If you lack self-confidence, it will be evident to the patient or to the patient's members, and then how are they supposed to put their trust in you if you don't have trust in yourself? If you have self-confidence, it shows that you are secure in your abilities. The ability to communicate verbally and in writing is very important. You also need to be able to adjust your communication strategies to meet various situations that may come up in the pre-hospital arena. You need to be able to manage your time well so that you can be on time, that you can perform tasks in a timely manner. because ultimately this will affect patient care and the outcome of the patient. Teamwork and diplomacy are important goals to achieve. You should always put the success of the team above your own personal success. You need to have regard for others and show respect and consideration and appreciation of their importance. With regard to patient advocacy, you are sometimes the only person that's going to stand in the gap between the patient and other health providers. You should not impose your own beliefs on other patients, but you should provide patient confidentiality and not allow your personal opinions to have an impact on the care that you provide your patient. We have a duty to have careful delivery of services. We need to evaluate our performance and our attitude on every call and look for continuous quality improvement. That is part of patient advocacy. So, what are the roles and responsibilities of a paramedic? Paramedics need to provide the optimum care on scene, from scene, between facilities, and your roles and duties can be divided into primary responsibilities and other duties as assigned. So I've given you here a basic breakdown of what the primary responsibilities should be for a paramedic. Now, other duties as assigned, that can be kind of broad. That'll be the things like community involvement, support of primary care efforts, advocacy for public involvement in the EMS system, participation in leadership activities, personal and professional development. Be a role model for the profession. Go out and teach CPR, first aid, illness and injury prevention. Create a community awareness program for how to use EMS in the right way. That can be other duties as assigned. Also, encouraging your local community to be involved in EMS, take part in leadership activities in the community, and assist media campaigns to promote EMS issues. Those things are other duties as assigned. The paramedic also has a responsibility for personal and professional development, becoming involved in work-related issues that affect career growth, exploring alternative career paths in the EMS profession, conducting and supporting research initiatives, and being actively involved in legislative issues related to EMS are all other duties as assigned. Nobody is going to look at EMS as a profession unless you look at it as a profession and unless you act responsibly and professionally. We are walking billboard. What you display to the general population is how all of us are identified. So keep that in mind in your EMS careers. Medical oversight of EMS systems, because they allow us to perform our job. The primary role of the physician medical director is to ensure quality patient care. Medical directors ought to be knowledgeable about EMS operations from soup to nuts, from the design and operation all the way down to communication with external professional organizations and everything in between, like credentialing, advocacy, development of protocols, direct input on patient care, training exercises, and education of EMS personnel. Indirect medical oversight can be prospective or it can be retrospective. Basically, prospective medical oversight means treatment protocols. Retrospective oversight would be continuous quality improvement, reviewing a run sheet and providing some guidance on what you should do the next time you see a patient that presents this way. So that's just some of the ways that medical oversight can affect EMS systems. We sometimes on scene may have more help than what we want. Maybe we have a physician bystander on scene. Although that's a rare occurrence, it can happen. What you're going to want to do in this case is contact your medical director, contact medical control, and say, you know, I have a physician here on scene. He wants to take control of patient care. If medical direction over the radio says that's fine, then make sure that physician, you know, signs a document accepting responsibility for the patient. If a physician on scene, though, is in opposition of what your medical director says needs to happen with the patient, if you cannot remove the patient from the scene, then you may need to involve law enforcement. All things need to be done with the patient's best interest in mind. The major goal of any EMS system is continually evaluating and improving patient care. So in order to do that, we need to do continuous quality assurance and continuous quality inspection. That involves the medical director. I want to tell you, there was something called EMS at the Crossroads. It was a report that was written by the Institute of Medicine. By the way, the Institute of Medicine is now known by another name. It's called the National Academy of Medicine. But they wrote a report in 2007 called EMS at the Crossroads. And here's what they found. They found that EMS was not well integrated with the healthcare system. Big surprise. In addition to that, many inconsistencies were found in the level of care provided from one region to the next. The report stressed that very little was actually known about the quality of care delivered by EMS because there's no consensus regarding patient-centered measures of EMS quality. Well, this report was written in 2007. In 2000, that's when the EMS agenda was written, and the EMS agenda is what gave us the 5 points of training in EMS. So, did we have enough time between the EMS agenda for the future and EMS at the Crossroads to determine whether or not there was an improvement? Remember, for EMS education, we had 5 core components. We had a national core content, national scope of practice, national standards, national certification, and national accreditation. So EMS at the Crossroads identified that we were weak. And so then we developed continuous quality improvement initiatives. And one of those was the Institute for Healthcare Improvement Triple Arm. The Triple Arm basically looks at the cost of healthcare, the experience of the care provided, and the population health. Okay? And they say we need to improve the patient experience of care, improve health populations, and reduce the cost of health care. And we can only do these things if we have our patients complete surveys. That's the only way we can show that we are improving our quality of care and we are listening to our population base. What about patient safety then? Well, in 1996, again, the Institute of Medicine said They wrote a report called To Err is Human, Building a Safer Health System. They said as many as 98,000 people die in hospitals each year as a result of medical errors that could have been prevented. Preventable medical errors in hospitals exceed deaths in motor vehicle crashes, breast cancer, and AIDS. And that higher error rates occur in ORs, emergency departments, and intensive care units. And the thing that these things have in common is those are high-risk activities. Anytime it's a high-stress environment or a high-risk activity, there's a higher likelihood that a mistake is going to be made. One of the things that we did study in the pre-hospital environment, also in 2007, was medication errors. A survey about medication errors was given to paramedics in San Diego, and we had 352 people respond. 63% of the errors were protocol errors, which means that they didn't read their protocol to find out what medication needed to be administered. A third of the errors were because medication was given by the wrong route. For example, an IV medication was given intramuscularly or something along those lines. About a fifth of the problems were, let me back up. Dose-related errors were 63%. Dose-related errors. So, dosage calculations. Paramedics could not perform simple dosage calculations, and so 2/3 of the mistakes were because of simple math. A third of the mistakes were because of protocol errors. A fifth of the mistakes were wrong route, the medication administered by the wrong route, and 4% was the wrong medicine. So the largest problem then for paramedics is dosage calculations. Now, how do we prevent that? Prevention comes in the form of practice. That's how we can prevent that. Patient safety can be improved on an environmental level as well as a personal level. So practice would be your personal level, and your environmental level would be look at your protocol book, confer with your partner, draw up the medication, verify with your partner that it's the correct medication, and then administer the medication. Patient safety should always be a high priority during every call. Errors that can cause injury or illness often involve handing your patient off at the hospital, communicating with other healthcare providers, airway issues. For example, if you intubate your patient on scene, you're moving them into the truck and out of the truck. Anytime you move your patient, you run the risk of moving your endotracheal tube. Lifting or moving your patient without adequate assistance or without using the proper equipment, ambulance crashes, and not immobilizing your patient properly. Those can all lead to poor patient safety outcomes. Some of these things can be improved environmentally. Some of them need to be improved on a personal level. This is it. This is the quick and dirty for EMS roles, responsibilities, and a short tidbit on professionalism. The material that I used for this lecture came from the Sanders Paramedic Practice 5th edition. And to leave you with a quote from my 8 times uncle would be Benjamin Franklin. Benjamin Franklin said, "I am persuaded that no common air from without is so unwholesome as the air within a closed room that's been often breathed and not changed." In other words, he said, if you don't get out in the fresh air you're just breathing unwholesomeness. Go out and experience the world. Go out and talk to other people.